So to begin with my disclosures, I'm the Associate Director for the MDG Center for Medicinal Cannabis Research. I have consulted Health Canada for setting limitations on amount of cannabis for personal use. I hold grants from CAHR to study the effects of cannabis on chronic pain and have no for-profit relations to declare. In terms of background, cannabis has been legally available for select medical conditions in Canada since 2001. And licensed healthcare practitioners can provide authorization for patients to acquire medicinal cannabis. The number of individuals that have this authorization are tracked by Health Canada, and these numbers have been increasing substantially. In 2015, there were just shy of 24,000 Canadians that had received authorizations to use medicinal cannabis. Fast forward to September 2020, this number had gone up to over 370,000. So there is substantial and growing use. And we know from other studies that have been done that there are a number of Canadians that use cannabis for therapeutic purposes that do not have authorization to do so. There are costs associated with this use. In 2018, Veterans Affairs Canada reimbursed $75 million for use of medicinal cannabis by Canadian veterans. In 2019, this number went up to about $100 million. In 2020, it's gone higher still. When we look at the kinds of conditions that those authorized to use medicinal cannabis indicate they are using, we do have some data from the United States, where in 2017, there were over 800,000 Americans that were authorized to use medicinal cannabis. And of the complaints that were listed for that purpose, chronic pain was the qualifying condition reported by over 60% of patients, with much smaller numbers using for multiple sclerosis, chemotherapy-induced nausea and vomiting, PTSD, and a few other causes. Now, there has been some guidance in terms of the evidence surrounding use of medicinal cannabis for chronic pain. The most recent guideline, which came out about a year ago, was from the National Institutes for Healthcare Excellence. This is in the United Kingdom. And they made a strong recommendation against the use of medicinal cannabis for chronic pain. More recently, the International Association for the Study of Pain released a comprehensive series of review articles and recommendations, and they made a statement where they also made a strong recommendation against the use of cannabis to treat chronic pain. So, what's going on? We have a lot of individuals that are acquiring cannabis for this purpose. We have two authoritative organizations that are making strong recommendations against such use. So should this be discontinued? Well, we weren't sure. So we undertook a rapid evidence synthesis and guideline on this topic. Our question, as you can see here, is in adults and adolescents living with chronic pain secondary to cancer or non-cancer causes, should we recommend a trial of medicinal cannabis or cannabinoids versus continued care without these products? And we could come up with 4 different recommendations. We could either make a strong recommendation against, or we could make a strong recommendation in favor. And that would imply we had strong evidence suggesting that patients, virtually no patient should pursue this, or virtually all patients should pursue it. And in the middle, we could make weak recommendations, either weak in favor or weak against. And what that would mean is that the decision will vary from patient to patient. Weak recommendations are an opportunity for shared decision-making. Strong recommendations are an opportunity to make quality of care standards. So how do we come up with these recommendations and these strengths? Well, we use something called the grade approach. And in order to make a strong recommendation, we need to see a very clear imbalance. And what I mean by that is we need to see compelling evidence that either the benefits strongly exceed the harms, in which case we would make a strong recommendation in favor, or compelling evidence that the harms clearly exceed the benefits, in which case we would make a strong recommendation against. And we have to be confident that the quality of evidence is high. And we have to understand that patients provided with this information would almost all make the same decision. Now, a weak recommendation is different. A weak recommendation means that we often have a close balance between harms and benefits. And therefore, the individual decision is very sensitive to the values and preferences of the individual patient. We may be in a situation where the quality of the evidence is not very high. So we're not confident in the effects on either the benefits or the harms. And by providing this information to patients, we may learn that there is a wide range of preferences. Some might choose to attempt a trial of this product, some may decide against. So these are the differences. These are the different situations under which a strong recommendation can be made and a weak recommendation can be made using the GRADE approach. The perspective of our guideline was patient-centered, so we did not consider the perspective of payers or society. There were 21 individuals on the panel, comprised of clinical experts, methodologists, and 3 patient partners who lived with chronic pain, including 1 veteran. And importantly, no one on the panel had any financial conflicts of interest or any important intellectual conflicts of interest. You heard in the last presentation a little bit about this, where if someone has spent a lot of their career promoting a certain perspective, if they've led a number of studies that made a certain conclusion, that it may be very difficult for them to divorce themselves from that perspective. So we believe that as well, which is why we took into account both intellectual and financial conflicts of interest. Now, to begin our exercise, we undertook a systematic review of patient values and preferences. So we looked for any studies that had reported on the values and preferences of individuals who live with chronic pain, who either did or did not use medicinal cannabis, as well as the value and preferences of their carers, if represented, on the relative values or importance of outcomes related to medicinal cannabis use. What value did they place on certain beneficial outcomes? What value did they place on certain harms? We wanted to understand the attitudes or preferences for or against the use of medicinal cannabis, for different administration routes, ingestion methods, or formulations. And we wanted to understand the factors that influence patients' decisions regarding whether or not to use medicinal cannabis. So we found 15 studies that had been conducted in this area. They all reported patient values and preferences of adults. Most of them enrolled patients from the United States. However, we did have some studies in the UK, Israel, 1 in Canada, 1 in Australia. And these were all fairly recent publications conducted from 2000 onwards. Both cancer and non-cancer patients were represented. And when we synthesized this evidence, we found moderate to high certainty evidence that many patients value the effectiveness of medicinal cannabis for symptom management, even when experiencing adverse events related to concentration, memory, or fatigue. We found there was a greater preference for products that were either high in CBD or that had balanced ratios of THC to CBD versus high concentrations of THC. And we heard this from the presentation yesterday, that recreational cannabis users appear to be systematically different from those that use cannabis therapeutically. And certainly when it comes down to preferences around THC concentration, this does appear to be a distinguishing factor. We learned that cannabis use was influenced by both positive social consequences, support from family and friends, and negative social consequences, stigma surrounding cannabis use. Up until quite recently, this was an illicit substance. There's a long history to cannabis. There were concerns about medicinal cannabis, including side effects such as addiction, tolerance, losing control or acting strangely, and patients that had elevated levels of these concerns were less likely to be interested in the use of medicinal cannabis. We found low certainty evidence that there was highly variable attitudes towards medicinal cannabis amongst people living with chronic pain. And we also learned that patients were motivated to use medicinal cannabis to reduce use of prescription medicine and felt that it was safer than opioids. Again, you heard in the last presentation that cannabis is often touted as a natural product Just because it's natural doesn't mean it can't have harms associated with it, however. Now, what's interesting from those two guidelines that I presented at the beginning, the one from the NICE organization, the one from the International Association for the Study of Pain, is they did not systematically explore patient values and preferences. So this is a piece of information that we used that was not available to the prior guidelines. And we then undertook a systematic review of randomized controlled trials that administered medicinal cannabis products versus any kind of non-cannabis control for the purposes of managing chronic pain. We found 32 trials, 28 enrolled patients with chronic non-cancer pain, and 4 enrolled patients with chronic cancer pain. These were all adult populations with a median age of 54. Length of follow-up was not particularly long, but we set a minimum cutoff of at least 1 month, and we had at least one trial that went up to 140 days. Placebo was the most common control. In terms of the type of medicinal cannabis that was administered, we had 5 trials that looked at an endocannabinoid, 20 that used phytocannabinoids, which were derived from the cannabis plant, and 12 that used synthetic cannabinoids. Modes of administration included predominantly oral or spray, so these were capsules or drops, one sublingual, and 2 trials looked at topical preparations of CBD. Now, what's interesting and what you might have noticed is that none of the eligible trials explored inhaled cannabis. Why is this important? Well, if we dig down at the data in terms of the kinds of products that Canadians are accessing, those that are authorized to use medicinal cannabis, by and large, the majority are accessing dried flower product. Well, that type of product is typically taken in through either smoking or vaporizing. So the predominant method of use in Canada for therapeutic benefits is taking cannabis in a way that is not represented in the clinical trials that we have to draw on for evidence. And I think that it's reasonable to assume that if you're inhaling something, you're taking on board additional risks in terms of lung harm that you would not take in if you were ingesting something. So we saw an interesting disconnect between the way these products have been administered in clinical trials and the way in which many Canadians are currently using them for therapeutic purposes. This is called a great evidence profile. It's a bit of a busy table. I'm not going to go through all of it in detail. This is looking at the benefits from the randomized controlled trials. And what we have here in the first column are just outcomes. We have pain, physical functioning, emotional functioning. And we have follow-up, and then we have the treatment effects. And what you can see here is on a 10 centimeter scale for pain, we get an improvement of 0.5 centimeter for those individuals that were provided cannabis versus a placebo. Now, how do we contextualize that? You heard from the last presentation the term responder analysis. Well, we can model the proportion of patients that achieved an important benefit based on what we know about the minimally important difference on this scale. And when we do so, we see that 10% more patients that were provided with medicinal cannabis reported an important reduction in pain versus those provided placebo. And again, I want to highlight, though, if you look at the proportion that achieved an important benefit, it's about 52% of those in the placebo arm, right? So it's a very impressive 62% in the cannabis arm, but the risk difference is 10%. And again, this highlights the importance of conducting randomized controlled trials versus observational studies to really get a sense of what the specific effect of cannabis is in different patient populations. We had moderate certainty of evidence in this. And in terms of summarizing it, we determined that cannabis probably results in a small increase in the proportion of patients experiencing an important reduction in pain. When we look at physical functioning, we also see a significant benefit of cannabis over placebo, but this time the risk difference is even smaller. It's only about 4%. So in this case, whereas you have to administer medicinal cannabis to about 10 patients with chronic pain versus placebo to get 1 to benefit, when it comes to physical functioning, that number is much closer to 25. So We have high certainty evidence, but in this case, cannabis results in a very small increase in the proportion of patients that will experience an important improvement in physical functioning. In terms of emotional functioning, we have high certainty evidence that cannabis does not produce any significant effect. If we look at what NICE said about the effects on pain, they concluded that the treatment effect was modest. They said an average improvement of about 0.4 on a scale ranging from 0 to 10. And if you look at the paper, they actually concluded there was a mean difference of about 0.44. Well, that's very similar to the effect that we found. Now, we pooled a lot more trials than they did. They pooled 11, we found 27. But the effects are very, very similar. So why is it that NICE concluded that their effect was unimportant, and we felt that our effect might be important? Well, we both did a similar thing in terms of looking at the minimally important difference, the smallest amount of improvement that needs to be achieved for a patient to notice that effect and to perceive it as significant. And it's about 1 point on this scale. So because this value was less than a point, they declared that it was unimportant. Well, why didn't we? Well, not everyone has the same reaction. As you heard in the preceding talk, some patients notice a fair bit of improvement, some patients notice none, some patients might even find themselves getting a little bit worse. So you can't apply the average effect across every patient. So what we did is we modeled the proportion of patients likely to achieve an important benefit. That was 10% in terms of the risk difference. And when we presented that to our panel, including patients, they perceived that patients who lived with chronic pain might find a 10% chance of improvement important enough to consider this therapy. And to give this some context, a few years ago, we published an overview on the use of opioids for chronic non-cancer pain. And what we found was, compared to placebo, there was about a 0.69 centimeter improvement on that 10-point scale. Quite similar to what we found the average effect was for medicinal cannabis. So again, if we focus only on the average effect, I think that we run the risk of making the assumption that everyone has the exact same response. And what we know about treatments for most conditions, and in particular chronic pain, is there is variability. Not everyone will have the exact same effect. And so we think that modeling the responder analysis, the proportion of patients likely to benefit, is a more helpful way to convey the effect. Now, what did the IASP say about effects on pain? Well, they concluded the evidence was very uncertain due to risk of bias. So what happened? How did we end up concluding high certainty evidence and the IASP concluded very low certainty evidence? Well, here's what we found for risk of bias. Amongst our 32 trials, 63% adequately generated the randomization sequence. Almost all the trials did a very good job of concealing allocation and blinding patients and healthcare providers, and about half the trials had substantial missing data. So the IASP saw something similar, and they said, well, because some of these trials, and in some cases with respect to missing data, quite a few of these trials are at risk of bias, we are going to rate down the certainty of evidence. But there's a different approach to use. What you can do is run what we call a subgroup analysis. And what I mean by that is, do the studies that are at risk of bias, and we say at risk because we don't know if the bias has been realized. Do those studies at risk of bias provide systematically different estimates of treatment effect? And if they do, well, then we should only look at the studies at low risk of bias. But if they don't, then we can confidently pool them together and conclude that the risk was not realized. And so this is what we found when we looked, for example, at adequate randomization. We had 16 trials at low risk of bias, and they actually found a larger improvement in pain versus the 11 trials at high risk of bias. Now, when we looked to see if the difference between these was statistically significant, it was not quite. right? We set our level of significance at 0.05. This was 0.08. So we said the risk of bias doesn't appear to be realized, but if it was, we would have only pooled these studies and reported a larger effect on pain. We did the same thing with loss to follow-up. What we're worried about with loss to follow-up is that patients who are doing worse, who are not achieving a benefit, are more likely to abandon the trial. And we didn't see that. We didn't see a significant difference, and it went in the opposite direction. The trials with higher loss to follow-up actually showed greater benefit, and there was almost complete confounding by clinical indication in the sense that the trials of chronic cancer pain had almost no missing data. So again, we looked to see if a subgroup effect was present, if the trials at risk of bias were giving us systematically different effect estimates. They were not. So we pooled across all the trials and did not rate down for risk of bias. What about other outcomes in terms of benefits? In terms of goal physical, this is how someone is functioning at the workplace or at home. We found high certainty evidence that cannabis does not improve goal functioning. High certainty evidence that cannabis does not improve social functioning. We did find a small increase in the proportion of patients likely to experience improved sleep quality, risk difference of 6%. Again, what this would equate to is you'd have to provide cannabis to about 17 patients versus placebo in order for one to notice an important improvement in their sleep quality. Now, what about reducing opioid dose? And again, you heard from the prior speaker that this is an area of great interest. Well, when we looked at the NICE guideline, they concluded that that cannabis did not allow patients to reduce the amount of opioids they were consuming. We looked at the same trials and we also found that there was no significant difference. This is a weighted mean difference of a little over 3 milligrams morphine equivalent with an estimate of precision that shows no significant effect. But we rated this down to very low certainty evidence. Why did we do this? Well, it's because all of the 4 randomized trials that reported this outcome also instructed patients not to change their dose of opioids during the trial. So this is a terrible outcome to then draw any conclusions from. If you're telling patients don't reduce your dose of opioids and then you find that there was no reduction, that doesn't mean that there was no effect. It means you directed patients not to make any changes. So we downgraded this to very low certainty evidence because of indirectness. Because of the problems with the randomized trials, we looked at the observational data. We did find 6 studies, total of 710 patients, where it was uncontrolled, but they provided individuals that were using opioids for chronic pain with access to medicinal cannabis. And overall, they did find a significant reduction. When we pooled across all studies, the average reduction was about 20 milligrams morphine equivalent per day. But again, because of the unblinded nature and the lack of a control group of these observational studies, we again rated down to very low certainty evidence. So at this point, although we have high confidence or at least moderate certainty evidence for most of the beneficial outcomes, we really are uncertain about the potential for opioid substitution. Now that's benefits. What about harms? We need to provide patients with evidence not only on benefits, but also on harms. So we do see small increases in the risk of cognitive impairment. Again, it's a 2% risk difference, so quite small. Vomiting is a 3% risk difference. Drowsiness, 4%. Dizziness is larger. It's 8% for trials that followed patients for 3 months or less. It goes up to 33% for those few trials that actually looked at use longer than 3 months. If we look at impaired attention, it's a 3% risk difference. Again, so you've got 1% in the placebo arm that reported this versus 4% in the cannabis arm. For diarrhea, risk difference is 4%. And for nausea, 5% more individuals that received medicinal cannabis reported this than those that received placebo. So we do have evidence for a number of modest transient harms, but the effects in general are quite small. Now, what about the more serious adverse events, the ones that might take longer to manifest? We don't have that information from randomized controlled trials, so we turn to the observational literature. And we did find some information to inform the risk of cannabis dependence, motor vehicle accident causing injury, falls, suicidal thoughts, and suicide itself. But all of the evidence was very, very low certainty. Small numbers of trials, modest numbers of patients, a lot of uncertainty. So we don't have a strong sense of what the true risks are for these outcomes. The evidence that we have suggests that the risks appear to be quite modest, but the certainty we have in this evidence is very low at this time. To whom do our recommendations apply? Who is represented in these trials and these studies that we looked at and who are not? Well, as I mentioned before, no trial eligible for our systematic review explored the effect of inhaled forms of medicinal cannabis or enrolled patients involved in palliative care. So our recommendations do not apply to those patients. They certainly don't apply to recreational use of cannabis. Trials eligible for our reviews largely excluded people living with chronic pain with concurrent mental illness, or those receiving disability benefits or involved in litigation. And they did not report the representation of veterans. Therefore, the generalizability of our findings to those groups is uncertain. So I began this talk by talking about the kind of criteria that would need to be met in order to make a strong recommendation versus a weak recommendation. So to reiterate that, strong recommendation means unequivocal imbalance. The benefits clearly exceed the harms, and the harms clearly exceed the benefits. All patients looking at that information would come to the same conclusion. I would argue we don't have that. We have evidence for some benefits in a minority of patients, and not on every beneficial outcome. Some benefits on pain, physical function, and sleep, not across the other items that we looked at. We do have evidence for some harms, but again, it's small. Risk differences typically range between 2 and 5%. So I would argue that we have a pretty close balance between benefits and harms. And so it's very likely that patient values and preferences are going to be a key determinant in deciding whether or not a trial of medicinal cannabis might be appropriate. So in this case, I would argue our final recommendation either is going to be a weak recommendation in favor of a trial of medicinal cannabis in addition to standard care for people living with chronic pain, or a weak recommendation against. The guideline is going to be coming out in a couple of months, so I'm not going to give you the sort of final determination, but in either case, it's a mandate for shared decision-making. It means that not all patients are going to make the same decision. Patients are going to need to see the evidence for benefits, the evidence for harms, and encouragement to make a decision that is consistent with their values and preferences. As you heard from the last speaker, cannabis does not appear to be a panacea. It might work for a minority of individuals. There's also practical considerations. We recently published the results of a qualitative study in CMAD Open last month, where we conducted interviews with a number of family physicians in Ontario about medicinal cannabis. And we heard very clearly that this is not an area that they've received comprehensive training in. There's a great deal of uncertainty about dosing, about titrating, about tapering patients if the decision is made to come off, about what kind of product to use, and what kind of formulation, and what mode of administration. So there's a lot of questions out there that clinicians need to have answered before they can work with patients that are considering this kind of product. There are some consensus-based recommendation papers that are starting to emerge, but we do need more evidence in this area to provide this kind of guidance. And I thank you for your time, and I'm happy to take any questions that might be out there.
Great, thank you, Jason. So some questions. First question is from William. When it comes to the difference in administration between clinical trials and therapeutic use in Canada, is popularity and expected duration of effect a potential explanation for the divide? Since edibles and other methods tend to have effects that last longer and take longer to kick in, people may be more comfortable with administration that can be arguably more easily controlled and guided by someone more experienced.
So it's possible. This is an argument, that someone needs a very fast mechanism of action. If you're taking something in through ingestion, it has to go through your digestive system. It can take an hour or even more to become effective. Whereas if you inhale something, the effects are felt within minutes. But I would argue that for chronic pain, the large majority of individuals, probably almost everyone dealing with chronic pain for a period of time, will come to understand their symptoms, and they get into a routine in terms of their treatments where they don't have to wait till the symptoms become unbearable. Certainly, to use the example of opioids, which are commonly prescribed for chronic pain, it would be much quicker to get an effective opioids if it was injected or if it was smoked, for example. But we don't do that because doing it in this way increases the risks of certain harms. Instead, what we do is we help patients to understand their pain schedule so that they get on a routine that allows them to take the next dose of a medication before that pain level starts to spike. So it becomes more about management as opposed to, I need something that's going to work within 30 seconds immediately. So yes, it's possible that one of the rationales for you using it in inhaled form is to get a very fast mechanism of action, but whether or not that's an appropriate trade-off for the harms that you have to accept by, inhaling all sorts of particulate matter into your lungs, I'm not so sure.
Amy asks, what is your citation, or is it not yet published? Are we able to present this data? I'm giving grand rounds and would like to include this.
It's currently embargoed, so it is. I hope soon to come out, but I don't have a citation for you at this point, unfortunately. So anyone that's interested in getting the final citation in the document, which will include patient decision aids, which will include an online platform where the guideline will actually be in an interactive multi-layered format, which is available free for use. If you're interested, please send a note to Alan, and I'll make sure to get that as quickly as I can.
From Linda, is there any validity to the idea that cannabinoid therapy is sort of part art, part science with respect to finding effective products, titration for individuals? Yesterday, we heard about sativa versus indica, as well as entourage effects, etc. Everyone is different.
I think it's a great point, and I think that even came up in the first series of talks, or in the first talk that we heard today. There does appear to be some need to understand the response of the individual. When you talk about the fact that 1 in 10 patients appears to demonstrate an important reduction in pain, well, what makes that one person different from the other 9? We're not entirely sure. So at this point, because we cannot say with great accuracy who is likely to benefit versus who is not, it does become a trial of different types of treatments that are available out there. And unfortunately, when it comes to chronic pain, there does not seem to be a treatment that works for everyone. There are some treatments that work for some and not for others. And even if medicinal cannabis does provide some benefits, the formulation that someone else is using might not work as well for you. So I think there is a need to do some of this individual, N of 1 trials where we start off with something, I would assume a sort of a safe starting point would be to go towards a CBD dominant product, to titrate that up to see if there's an adequate response. If not, to then look at bringing on board some THC into that as well, and to see if there's a response, if the response outweighs any adverse events for the individual. But I think there is going to be a need for some individual titration for patients in order to see if it might be something that works for them.
A question from Roman. What is your view of the cannabis medical clinics that routinely provide cannabis for medical purposes without actually doing the trial? How long would you titrate up before abandoning a trial?
So I would really refer you to the consensus document that I highlighted on the second last slide, and there's another one that I know that's under review that I expect will be coming out shortly that does provide some guidance around duration, how much time to take, the sort of maximum that is recommended by experts out go in terms of milligrams of CBD or even THC if you end up moving on to that. I think that we did hear when we talked to the family physicians that we spoke to for the study that I alluded to that came out in CMAJ Open last month, there was some concerns about the cannabis clinics, that they, at least for some patients, appeared to see a lot of enthusiasm for authorizing medicinal cannabis to individuals that in some cases were quite young, to individuals that had comorbid mental illness. And so the short answer is I'm not sure. I think that some of the clinics probably have individuals working there that have developed a lot of expertise working with a product where there's not a lot of formal guidance and education provided. But there was concern amongst some of the family physicians that we talked to that it seemed to be quite easy for a number of their patients to gain access to medicinal cannabis through these clinics. And they weren't always convinced that their patients had been given a thorough description of the evidence we have for benefits and harms.
A question from Linda. Cannabinoid therapy as an adjunct therapy. What, if anything, does the research say about this?
So most of the trials that we looked at, in fact, almost all the trials did use cannabis as an add-on therapy. So they did not mandate that patients had to discontinue all treatments that they were using. And I think that that's similar to what you heard about CBD in terms of its usage in the trials to treat some of the pediatric seizure disorders that were presented this morning, where it was not a replacement therapy, it was not a standalone therapy. In the trials in which it was tested, it was an add-on to what patients were otherwise receiving. There is interest in looking at to what degree patients might be able to reduce their use of other medications. In particular, opioids has come up a lot as whether or not there might be a substitution effect. But in the trials that we read that were used in our review, cannabis was not a standalone therapy. It was an add-on to the existing therapy.
Question from Terry. Given that physicians don't feel they're well-trained or well-informed, could your group's recommendations potentially help them have a useful discussion with their patients and provide better advice on what constitutes an adequate trial with a product that is more likely to be effective?
Yeah, it's a great point. So the initial guidance that we put out was undertaken very quickly, and it was undertaken in part because we knew there was a lot of confusion out there, both amongst patients and clinicians. We were aware that there was some very strong recommendations coming out for certain groups, and we wanted to explore this ourselves quickly. We have been very fortunate to have been funded recently by CHR to undertake much more comprehensive guidelines. And so we're in the process of doing that. And part of that exercise will be to get at exactly what you're talking about, Terry, which will be, look to where we see evidence so that we can provide that guidance. In areas where we don't have evidence, we will look to clinical experts to provide guidance statements. And I'm fairly confident that we will have to rely on that in terms of dosing, in terms of different types of preparations or modes of administration, so that we can provide some of that practical guidance, until the time that we do have more high quality evidence from trials to draw upon.
The next question, the available evidence suggests that milligram doses of THC have a therapeutic effect, but some patients / MDs are using or authorizing large amounts of cannabis in grams. What are your thoughts on the safety and efficacy of using such large amounts of cannabis? Is there any evidence to suggest a potential rationale or benefit of using such high amounts of cannabis per day more than 10 grams per day, for example?
Yeah, this is a very active area of debate. So I know, for example, Veterans Affairs Canada used to authorize, I believe it was around up to 7 grams per day for therapeutic use, and in 2016 that was reduced to 3 because they were not seeing that in the clinical trials that had been done that those kinds of higher amounts had been administered. So they were trying to better align what was authorized with the evidence from the trials that was out there. So I would agree that if you look at the clinical trials that have been done, they have not focused on these sort of very high doses up to 10 grams of dried product per day, and so there is a real question out there: to what degree are those much higher doses required? To what degree might there be some sort of dose-dependent harms that you might have to accept to use such high doses? We don't have great evidence to really say right now. What a lot of groups have been doing is they're sort of saying, well, what has been tested in trials, and if that showed an effect, then maybe that's what we should start with in clinical practice. And if patients are reporting partial benefit and they may wish to try to go a little bit higher, then that's a discussion they have with their healthcare provider, and they can see if perhaps they might see greater benefit at a higher dose. But we don't have great clinical trial data out there in terms of dose findings. So you saw in the prior presentation, they'd actually done those trials. They looked at doses of I think it was 10 milligrams per kilogram versus 20 milligrams per kilogram of CBD, and they found that the benefits were fairly similar, but there was much higher harms at the higher dose. Therefore, with Epidiolex, they have landed on that lower dose in terms of the recommended usage. We don't have those kinds of trials yet with medicinal cannabis, but we do need them.
Question from Amy. How much of your center's funding is from industry, and can you comment on this?
Zero.
We are conducting.
we have no funding from industry. We are extremely conscious of the optics. We are extremely conscious of the potential for conflict of interest or risk of bias. I would highlight the points made by the first speaker that it is critical that we maintain a distance from industry. It's not because we don't feel industry has an important role to play. They obviously do. There are critical initiatives and projects that industry is funding. But in terms of the Center for Medicinal Cannabis Research at McMaster, we have made a conscious decision that we will not get directly involved with industry funding. We do not have it supporting any aspect of the center, and neither myself or Dr. McKillop have any for-profit relations to cannabis industry.
Would your advice differ for cannabis that is richer in CBD versus THC?
Well, what we see when we did our review of patient values and preferences is individuals that are using for therapeutic purposes are much more disinclined to gravitate towards high THC products. They are much more interested in high CBD or in balance ratios. And I think that's probably because CBD is not psychotropic, as you heard. You're not going to get the euphoria. You're not going to get the high. For recreational use, that clearly is the kind of product that would be selected, that would be prioritized. For therapeutic use, it seems that the product that is much more desirable are those that are either high CBD or those that have a balanced ratio of CBD to THC. So I think that in terms of therapeutic use, that's where you're seeing a lot of the attention being driven, both in clinical trials and in practical administration.
Question from Linda. I believe this is the Wild West in some ways. Everyone over the age of 19 can walk into a cannabis store to purchase cannabis without guidance. Clinics are better because they have healthcare practitioners and provide ongoing support for patients. This is obviously not ideal. It is perhaps a stopgap. What is the answer until physicians are more fully trained? Should there exist a professional program for cannabis clinic educators and workers?
So I think it would be great to have a standardized program so that the information being provided was very similar from clinic to clinic. we've got, I've certainly spoken to a number of patients that have gotten a lot of their advice from a bud tender at a dispensary, or they've had to go online, or they've talked to family members or friends. There's, in the absence of a source of information that is widely acknowledged and accepted as authoritative, people are going to reach out to any sources of information that they can get. And I think that, again, describing it as a Wild West is quite accurate. You can go to a number of different sources and get very different information. And I don't think that's optimal. So I do think we need to find a way to provide more structured guidance, to provide more evidence in this area, so that you don't get such high variability in what patients are hearing. In terms of how that needs to be unfolded, we're obviously hopeful that the guidelines that we have coming out soon, and the more comprehensive ones that we're working on, will be an important part of that. But what I'll say is this: we acquired and were successful in getting not only the funding from CHR to develop the clinical practice guidelines, but we were also successful in getting 3 years of funding after the guidelines are completed to focus on a dedicated knowledge transfer and exchange program of research. So this means we are going to be exploring ways to get the information into the hands of patients, into the hands of clinicians, in a way that will hopefully see a lot of the variability out there disappear, and to hopefully optimize the use of medicinal cannabis for chronic pain in a way that's consistent with the evidence that we find. So I think it's a critical issue, and it's one that we really hope that we can have an impact on once the guidelines are complete.
We also do have, through continuing education at McMaster, we do have a set of courses and a certificate program in the science of cannabis. So if there are people who are interested in more information than we're giving in these lectures over the next few days, that is another avenue that goes into more details about similar topics. Another question: how can we convince LPs who already have access to the market to actually fund the expensive RCTs required to show efficacy and safety of cannabis and cannabinoids in various therapeutic areas? Any way we could incentivize this? Academic institutions have limited funding. I also don't know, Jason, if you want to talk at all about your experiences with clinical trials and getting those off the ground at this point.
Sure, I'm happy to do that. So it's a mixed bag out there from our experience. So in our experience, there are a number of licensed producers that are quite interested in getting involved in research. And we always begin our discussion with them with the same caveat, and that is, we are going to publish the results whether they are positive or negative. As you heard from Dr. McKillop yesterday, we are not pro-cannabis, we are not anti-cannabis. We simply want to understand what the science is going to tell us. So the good news is there's a number of LPs that are interested. One of the difficult issues is that there are 2 bars out there in terms of accessing medicinal cannabis. If you are a patient that wants to access it for therapeutic use, it's quite easy to do so. If you have an internet connection and a credit card and you can provide proof of age, it can be delivered to your door. As a clinical trialist, if I want to get it for use in a study, in a randomized controlled trial specifically, it has to be manufactured according to something called GMP standards, which is good manufacturing practices. And there has to be preclinical data establishing that the specific product that I want to use is not cancer causing and it does not pose a risk to a developing fetus. Because companies do not have to meet that bar to sell to patients, they have not. And so we have been working for a number of years now to find a licensed producer that can provide a product that will actually be approved for use in a clinical trial by Health Canada. And to date, we have been unsuccessful. So we have not been able to get to that next part that you mentioned, which is, can we get financial commitments from licensed producers to support these trials? At this point, we've been unable to find a product that we're allowed to use in a clinical trial, despite the fact that these products are all being used currently by hundreds of thousands of Canadians. So we need to find a way to address these regulatory challenges. And then absolutely, we need to find ways to incentivize industry partners to support the clinical trials, to look at the evidence behind the products that are currently available for therapeutic use.
All right, another question from Sultan. Have any of the clinical trial patients been introduced to cannabis before? If yes, would that make a difference in the effects of CBD on a patient?
The studies that we have seen have not provided the details what the experience was with cannabis prior to enrollment into the studies themselves. They did make clear that the individuals that were enrolled in the control arms, to the best of their knowledge, were not using or accessing cannabis. But again, you know, it's a good point. As you get into a situation, let's say in Canada, where we know that around 12 to 14% of adults have some experience with cannabis and a number are continuing to use at some level, is there a role for medicinal cannabis? This has come up in 2018 when cannabis was legalized in Canada for non-therapeutic purposes. There was some discussion by the Canadian Medical Association that perhaps there was not a role for therapeutic cannabis anymore. We did bring this up with the physicians that we interviewed for the study that we published recently. And in general, they felt that there was still a rationale to provide therapeutic cannabis for those that were interested. They felt that it was likely to be often fairly different products. They felt that it was likely to be better controlled and standardized. Whether or not an individual that has experience using cannabis would see different results than someone that had no experience, I think it's reasonable to hypothesize they would. But until we have those studies come out, it remains a hypothesis.
Question from Roman. Do you see the CPSO having a role allowing prescribing, much like methadone?
I'm not sure. I'm not sure. Right now, if you look at, all cannabinoids are controlled substances by Health Canada. But we know, for example, that CBD is not psychotropic. So it exists in kind of a funny space. So I'm not sure how the College of Physicians and Surgeons might undertake a role with these products in the future. We're still working through a lot of these issues right now with Health Canada to decide if it's going to stay as a controlled substance or if CBD is going to be moved out of that at some point, as it has in some areas of the United States. So I'm not sure what the future holds in that regard.
Question from Mahmoud. Thanks for your great talk. The findings about the efficiency of medical cannabis coming out from quantitative studies like systematic reviews are usually not so consistent with what patients expressed in qualitative studies. How do you explain this issue?
So I would explain it by sort of reiterating what you heard from the first talk, is when you're getting into unblinded administrations of a product, you are going to get different experiences than when it's administered in a controlled way where patients do not know what they're getting. As I showed on one of the earlier slides, if you look at the proportion of patients that received medicinal cannabis that reported an important benefit, it was about 62%. That seems dramatic. But in the control arm that received placebo, it was 52%. So again, if a patient is receiving something, they're often pursuing it because they have an interest in it, they have expectations, they've got certain beliefs and perceptions about it, and it's likely to sort of drive the reaction that they have. And it's only through the randomized controlled trials that we can understand what the specific effect is. Even in the studies that you saw that were presented on those sort of intractable pediatric seizure disorders, there was an effect of the placebo product, right? And you heard Dr. Davinsky mention how surprised he was that in a condition as serious as these intractable pediatric seizures, that there was such a high non-specific effect. But we do see this. We see this with a lot of chronic conditions. And so that's why we see a big difference between observational data and data from randomized control trials. Both are important, but the data from the randomized control trials take into account a number of issues that have the potential to influence the results.
Question from Nafisa. Are you aware of any studies assessing the financial impact of cannabis legalization on the healthcare system, for example? Would be great to assess the risk-benefit ratio of legalization. Are adverse and drug cannabis interactions being monitored? My understanding is that LPs only have to report serious adverse events.
I think you're right about the LPs having to only report serious adverse events. I don't think that there's systematic monitoring underway to look at drug interactions with medicinal cannabis. I think it's an excellent idea to look at the economic implications of legalizing cannabis. So we know, for example, from a number of before and after studies that have been conducted largely in the United States, that when recreational or medicinal cannabis becomes legalized, you often see a decrease in rates of use of certain prescription medications, particularly analgesics, anti-anxiety medications, medications used to improve sleep. We don't know if it's causal, right? This is observational data, but it does suggest that there might be the potential for some of these medications to be substituted in part, maybe in whole, by use of medicinal cannabis. You heard from the earlier talk today that a number of the drugs that are commonly used for conditions such as anxiety can have problematic effects. And so there might be value in terms of substituting to cannabis products in some cases. So what the economic implications of that are, if these effects are truly causal, I'm not sure. But I think that that's an important area of study that should be undertaken, in particular because Canada has become the first G7 country to fully legalize cannabis for both therapeutic and recreational purposes. We should understand the implications of that, both on health, both on healthcare utilization, and in terms of financial aspects.
We'll take two final questions. If you do have extra questions, please put them into the question and answer box, and perhaps Dr. Busse can stay on a little bit longer to answer them individually. So one question in the chat: do you think it may be better to include subspecialists such as pain, palliative, and medical oncologists who have expert opinion in managing chronic pain patients, as well as knowledge about medical cannabis prescribing, than only speaking to family docs alone in future studies, as the one that was most recently published in CMAJ Open?
Yes. In fact, we have recently completed a study, the same study, but interviewing pain specialists, so anesthesiologists and other individual clinicians that specialize in the management of chronic pain. So we've also completed a study speaking to patients living with chronic pain about medicinal cannabis. So we will have two other studies. You've read our mind. That's exactly what we thought we should do. So those two studies should come out later this year. And again, if anyone is interested, I'm sure we'll have an announcement on the Center for Medicinal Cannabis website. If you send a note to Alan, I'll make sure that they get sent to you as soon as they're available.
And the final question from Liz: is it possible that the placebo effects are being driven by natural shifts in the endocannabinoid system itself, and thus should not be discounted as unimportant? Have there been studies on this, i.e. 2AG and AEA level changes associated with placebo effects?
So to my knowledge, those studies have not been done. I certainly would not discount the placebo effect, but it does seem to be more active in certain outcomes than others. So for example, when I presented the effects on different beneficial outcomes, the area where we saw the sort of largest amount of non-specific effect was for pain. It was much less for physical function. It was largely absent for role functioning. So it appears as if the placebo effect can help reduce the perception of pain severity, and it might increase sort of generalized physical functioning, but quite a bit less But when it comes to actual role functioning, so, return to work, for example, we don't see as much there. So not discounting it, but it might be more active in certain outcomes than in others. And certainly it's an area where we need to learn a lot more than we currently know, and in particular about how the endocannabinoid system might be interacting with the placebo effect or the non-specific effect.